Good morning, this is Dr. Bedi from Bedi Hospital. I'm an obstetrician, gynaecologist and an infertility specialist. I've been in practice for the past 36 years in the field of obstetrics and infertility for the past 22 to 25 years. Infertility, as you know, could be due to a number of reasons. But when we see a couple, we normally say yes, we have to focus on the male as well as the female. That means the wife or the husband. And when we come to an infertility couple, I would always tell you that please evaluate the husband first. Evaluation of the husband means testing the husband, asking many history of basically stress, addictions, drug abuse, and last question asked is the semen analysis, or the investigation is a semen analysis. With all these questions asked and the basic semen analysis, we will be able to decipher if there is something wrong with the male or not. Now, when a female comes inside the OPD or comes for consultation for an infertility consultation, what is that we have to keep in mind? One is her age. Second is we have to see on ultrasound whether the uterus shape is normal, the size is normal, to rule out any fibroids, to rule out any polyps in the uterus which might hamper pregnancy. Second point, we look for any malformation of the ovaries or enlarged ovaries. Enlarged ovaries might harbor cysts, or they might harbor simple cysts which are easily treatable and they might disappear, or they might be blood-filled cysts, or they might be solid cysts which might decrease the egg formation and hamper fertility. So once we've done the basic transvaginal ultrasound, we go for further testing, that is the blood tests. Now these blood tests are basically to assess the functioning of the ovaries, and that can be done by certain tests called the AMH test, the FSH test and the LH test. All three are blood tests generally taken on the second or third day of the menstrual cycle. They tell us about the ovarian reserve of the particular patient. So once you assess the patient, that is you assess the couple, the next step would be to give the treatment to the patient and to suggest what is the best treatment available for the patient. When we start with a young patient where everything seems to be normal, that is the male is normal, the female is normal, we just have to assist the patient in increasing the quality and the number of the eggs. How is that done? That is done by taking medicine for a period of 5 days to increase the ovulation. Now with this, we monitor the patient on ultrasound, which is done from the 9th day of the cycle. This is again the transvaginal ultrasound wherein we see the growth of the follicle. The egg per se cannot be seen on ultrasound, but it is the follicle which grows slowly. From 10 mm it grows to about 18 to 20 mm, and that is monitored by us. We also look at the uterus side by side to see what is the best time for ovulation. Because if the egg has grown and the uterus lining is not ready to receive the egg, again there will be no pregnancy at all. Thus, the role of the ultrasound or the ultrasonologist is very, very important in a fertility setting. Once we have done this treatment, we've done ovulation induction, we try to time the intercourse. That is most important. As you all know, the fertilization occurs just after the release of the egg. That is within about 16 to 18 hours of release of the egg. We have to time the cycle and we have to time the intercourse at that particular cycle. Now, if the patient does not conceive with this kind of treatment, that is ovulation induction and a timed intercourse, we have to go to further modalities. But yes, we have to really assess the tubes of the patient, because if there are blocked tubes or there are tubes which are not working, nothing can achieve a pregnancy with this kind of a treatment. So the next higher treatment would be something called an IUI. Number of patients have asked me this question, what is an IUI? Whether it is really good for us or not? Well, IUI is, in other words, intrauterine insemination. So instead of really going ahead for a normal intercourse, we tell the patients that yes, the semen of the husband is taken on a particular day, it is washed very well, It is washed with different solutions, we call them media, and the highly active or the motile sperms are picked up and they are injected into the cavity of the uterus. And this is also time bound because we have to do it at the time of ovulation or egg rupture. The success of IUI is around about 10 to 15%. It's not a very expensive procedure, but it's worth a try if the tubes are open. So generally when we've done this, we normally tell the patient to try for about 3 to 4 cycles of an IUI. Generally the patients do conceive in about 2 to 3 or maximum 4 cycles, but unfortunately if they do not conceive, again we have to think of the next line of treatment. Now the next line of treatment could be anything varying from a laparoscopy, a hysteroscopy to rule out any polyp, to rule out the lining of the uterus, to look for any infections inside the uterus, again to look at the tubes, because at times we feel yes the tubes are open, but on laparoscopy we see that the tubes are not open, the tubes are closed, or the tubes are red in color, inflamed in color, or they're positioned abnormally behind the uterus, or in a few cases we get the ovaries which are stuck badly behind the uterus and they do not really help in achieving a pregnancy. So a laparoscopy tool also becomes very important in assessing the fertility of the patient. These were the preliminary tests which I told you which an infertile couple has. But the patients which come to us have already gone through all these treatments. They've gone through the semen analysis, they've gone through IUIs, they've gone through a laparoscopy, they've gone through a hysteroscopy. And what is left with us is only IVF or in vitro fertilization, because this is the test which tells us 1. The quality of the egg, 2. The quality of the sperm, 3. Whether the egg and the sperm are getting together, and number 4. Whether the egg and the sperm have produced a good embryo. This is the only test which really tells us yes, we have progressed so far as forming an embryo. Embryo is the first point of a fertilized baby. So embryo formation is very important. The others are not very good at assessing whether this patient is capable of having a baby or not. Being an IVF specialist myself, I would like to tell everybody that IVF in the best of hands is a very safe procedure. The medicines or injections used for IVF do not have side effects if monitored properly. The ultrasounds have to be done daily. The blood investigations have to be done daily. What is most annoying or very bad for the patient is the ovarian hyperstimulation syndrome, and that is the only complication of an IVF, apart from others when we do the pickup inappropriately or there's little bit of damage while taking the eggs from the ovaries, but that is always with experience it can be cut down.